So, Michael, you've been one of our leaders in translational science. What's the molecular testing now that we do once we've operated on a patient or begun chemotherapy? Is it just a germline test, and if it is, which one? Or do we also do germline and then test the tissue, which is called somatic testing?
Yeah, Brad, it's a great question. And again, another area that has undergone huge evolution in the last 5 to 10 years. So we've always known that 8% of ovarian cancer patients have a strong family history, and these are likely to be BRCA1 or 2 carriers. That's been around for a while, but what's changed is that we now know there's probably another at least 8%, maybe as high as 15%, patients who have a germline mutation without a family history in BRCA1 and BRCA2, and in addition, maybe a germline mutation in some of the other genes in the Fanconi pathway.
Right.
So this has, you think about it, this has huge implications, because these ladies come in, they have a diagnosis of ovarian cancer, and they don't realize that they have a germline mutation in one of these genes.
In the family.
In the family. And so I think that's been the huge step forward. It's a huge service to our patients to recognize that and insist that they get testing. Now, that's been really universally agreed to by all the professional organizations.
NCCN, ASCO, Society of Gynecologic Oncology, test everyone for germline,
Right.
and they say BRCA, but you tell me a panel, and I agree.
And I would say that despite the data, we don't do a great job in this country yet in testing everybody. The numbers I've saw between 20 and 30% of ovarian cancer patients being tested. So we need to do a better job at working at that. And these kinds of discussions will hopefully help. Panel testing is, that's what I do.
Sure.
It's here, I think it's here to stay. And then the only debate is what you alluded to is, I think some individuals in the community are going first to test the tumor rather than germline. And then if the tumor's positive, go back to the patient to test for germline.
So if the tumor's negative, the germline's always negative?
Correct, that's right.
Okay.
And if the
you think that's 100%?
Well, I
think-
mean,
think it's not-
this
I
is
think
the
there's-
issue, isn't
yeah,
it?
That's
right,
why
right,
I'm
right,
saying
right.
it.
I actually think that
Yeah.
that is the case. I think that's the case biologically. It's a technical issue.
Correct.
So if
That's
you get a
true,
piece
yes.
of tumor that has a lot of non-tumor stuff in it, you may miss it. So that's a concern. I don't know, the numbers I've seen, is the frequency of that is pretty low.
2%.
Yeah, but I think what's happening is it's a practical issue. So you're in the community, you're busy, you're working hard. If you refer a patient up front to a genetic counselor and to get germline testing, it might take several months. So the reflex is, okay, I'll send this off and I'll go from there. But it does have some challenges.
You know, you say that interestingly because we're going to talk about decisions that need to be made early in
Correct.
the treatment of that
Exactly.
patient.
Right.
And quite frankly, I don't have time to get authorization for genetic counseling and send it off to some lab and wait for 2 months. So counseling is important, but we have enabled and empowered our nurse practitioners to counsel. And so we have a whole process and SOP in place. You know, all you got to do is swab the cheek. So we think that testing for the tumor, although biologically important, it's too much work.
Okay.
I can have a newly diagnosed patient, I can activate that clinical pathway, and that patient will be tested, and then as she starts her first cycle of chemotherapy, I can begin to know whether, quite frankly, we'll get to it, whether I should start bevacizumab or withhold and treat it with a PARP inhibitor in maintenance, and the PARP inhibitor maintenance opportunity is only for the BRCA patients. But you may start a patient on bevacizumab without having the BRCA information, and then you're going to stop it, and then it becomes all confusing. So tell us what you're doing in Boston.
So, I mean, I think these are all really important points, and especially what we're going to talk about is SOLO-1, where it's really imperative not just to have this information for the patient's family, but for her treatment.
Right now.
Right now, no.
Yes.
So I think for us right now in Boston, what we're doing is germline testing. We're doing panel testing, really based upon the fact that it's, you know, the high-risk mutations are not just BRCA1 and 2, but there are at least 9 others that are reported through Mike's paper that collaborated with the University of Washington, showing other genes involved in the high-risk genetics of ovarian cancer. So patients diagnosed, first discussion is around treatment, and then the second point is about you need to get germline testing now. Okay. So we try to get the germline testing done, started within the first 3 weeks. after I see that patient initially.
Timing's important
Timing's
for germline
important,
testing.
yeah.
So we're
And-
getting
and-
somewhere. So we established.
Brad, can I just interrupt to emphasize again, based on that paper that we published
Yeah.
in the Swisher, it's independent of histology.
Yes,
Thank
yes,
you.
yes,
Age,
yeah, yeah,
family
yeah,
history.
Right, right, right.
Everybody should get it.
Okay.
Everybody, regardless, yes.
NCC and SGO and ASCO recommended. So we're getting somewhere. Every patient needs an operation in the beginning or between the 3rd and the 4th cycle. Every patient needs bracket testing early, probably a panel, and maybe even the tumor, and then chemotherapy.